Okay, welcome to UCSF Department of Medicine Grand Rounds. I'm Bob Walker, chair of the department. Today we're going to talk about lung and liver transplant, which are remarkable procedures. I think we've become a nerd to how breathtakingly audacious they are and effective they are and how many lives they saved. And we also happen to be at a place at UCSF where we're extraordinarily good at them and really world leaders in the procedures. The outcomes don't just reflect the technical expertises of the team members, and these really are team sports, but they also reflect the patient substrate and how healthy patients are or how unhealthy they are coming into the procedures. And our speakers today are really world experts on that matter, on the predictors of outcomes after transplantation, and particularly the role of baseline medical status and frailty. And they will talk about that while also talking about how to manage patients in the pre-transplant and post-transplant periods. So this will be a tag team. Our first speaker will be Jen Lai, who's professor of medicine in our GI division here at UCSF Health. She's a both general and transplant hepatologist who sees patients from everywhere from the early days of their liver disease to transplant. She is the director of UCSF Advancing Research in Clinical Hepatology, ARCH program, which is the research arm of our GI and hepatology division. Also is director of the patient-facing research core of our NIH-funded UCSF Liver Center. Jen got her bachelor's from Stanford and has an MD and MBA from Tufts, and did her clinical training in medicine at Columbia. And then we were lucky enough that she came here for her GI, hepatology, and transplant fellowships. It is a long haul. She's received a number of honors, including Top 40 Under 40 Leadership Award from the San Francisco Business Times, the American Gastroenterology Association Young Investigator Award, and several others. She's known to be a spectacular clinician, teacher, researcher, and mentor. So look forward to her talk. And joining her will be John Singer, who's now professor of medicine. I remember him when he was an intern, but now professor of medicine in the Division of Pulmonary Critical Care, Allergy, and Sleep Medicine here at UCSF Health. John really sort of has a parallel life with Jen, taking care of patients with advanced lung disease and including transplantation. He's also the associate medical director of the Advanced Lung Disease and Lung Transplant Program, and founded and now co-directs our Advanced Lung Disease and Transplant Research Program. John also received his undergraduate degree from Stanford, got his master's in health and medical sciences from Berkeley, and came here for his MD and has stayed on for residency, fellowship, and really a fantastic faculty career. And what I said about Jen, I could echo for John, a terrific clinician, teacher, mentor, and researcher and leader. So really privileged to have both of them on our faculty, and look forward to hearing the discussion today, which is entitled Frailty in Liver and Lung Transplantation, Past, Present, and Future. I think, Jen, you're first.
Thank you so much, Dr. Wachter, for the invitation to be here, and to the Department of Medicine for the invitation, and to everyone here who is present in the room, as well as everyone on Zoom. Hi. John and I have really been excited for this opportunity because we've been just dying for an excuse to collaborate together. So this was the great opportunity. So John and my research programs actually first started to converge over 15 years ago when we were accidentally paired together. It was definitely by accident because they did not know how much trouble we would get into if we started to hang out together. This was about 15 years ago when we were both T32 fellows in our respective fellowships, and we were put together in a T32 seminar. He was a pulmonology and transplant fellow. I was a hepatology and also a transplant fellow. And as we were sort of brainstorming over this year-long seminar about the unmet needs in our clinical practice and where we could direct our research programs for the greatest impact, we realized that although he and I are working on opposite sides of the diaphragm, we actually were struggling with the exact same problem.
And really, it comes down to our patients who were dying and disabled of end-stage liver and lung disease. Transplant offered them a chance to get back to doing the things in life that they found meaningful and to have a longer life. And as one example, this is one of my patients in the lung transplant program who, before transplant, was suffering from scleroderma-related pulmonary fibrosis, was in our ICU on 30 liters of high-flow nasal cannula with no destination other than transplant. Was able to undergo transplant. 8 days later, left the hospital and was able to return to a fulfilling life, playing in the band that he was the lead singer for, spending time with his wife and his daughter, and rock climbing. Just to orient us, transplant is not just the transplant surgery, but it's actually many steps in a journey. And it begins when they are initially referred to our transplant centers. And we undergo some fairly high-level, intense testing to see if they are physically fit and mentally fit enough to undergo the rigors of transplant. Then they're placed on the wait list, and they have to wait for some unpredictable amount of time on the order of days to sometimes years for a donor offer and maintain their candidacy. Then they go through a very complicated surgery fraught with challenges, both surgically as well as being exposed to toxic immunosuppressants. And then thereafter, on their journey to improve survival, quality of life, and disability, there are many challenges that emerge after transplant that could get in the way of that goal. Despite these challenges, most patients do really well, but for Jen and I, not enough did.
So John and I went into transplant aiming to get our patients to doing the things that they love to do, like John's patient who was in a band and rock climbing. But we found that in the course of getting there, there were so many obstacles that got in the way of our patients who we thought were going to recover from their lung injury or their liver injury. There were so many obstacles that just got in the way of them doing so. And you see, let me just back you up to this time when we were fellows 15 years ago to understand the problem. So at the time, evaluation and the way that we measured, assessed candidacy for liver transplantation was solely focused on how the lung or the liver itself was functioning, or I would say how poorly it was functioning, as measured by these metrics that you can see here. And in fact, these still persist in our field, but they are the only ways that we prioritize patients for transplant. The worse the liver function, the worse the lung function, the higher the patient is up on the transplant list. But, sorry. But what we were struggling with was that these metrics certainly captured the organ dysfunction itself, and they would go away with transplant completely. But these metrics seem to ignore the fact that these organs had to function within a whole person. And that's exactly what we were struggling with. And we would share stories during this year-long seminar of patients who would show up after transplant with perfectly normal liver tests, perfectly amazing lung function metrics, but for some reason, they just weren't perfectly functioning as a whole person.
And equally impactful to us were the patients who we listed for transplant and either died waiting for organs because they deteriorated, or after transplant died unexpectedly. And really, to the best of our knowledge, given the testing we had on them, we would have expected them to do well. And it really made us wonder, what was it about our organ-focused metrics at the time that we were not capturing?
So at that time, we had lots of conversations with the people we knew and trusted, and mentors in the field, including people with decades of clinical experience. And we asked them, well, how do you know if a patient is going to do well with transplant and not just have return of organ function, but have return of human function? And it always seemed to come down to this same phrase: you know it when you see it. And it was just always this gut sense. And while honestly, we absolutely trust the years of clinical experience of our mentors, the word that kept coming up was that this patient is just too frail for transplant. And John and I just couldn't, I mean, we know frail when we see it, but we couldn't help but think that maybe this eyeball test is maybe just too crude a metric to decide whether a patient should be listed for transplant or not, as well as being fraught with inconsistencies between one provider and another, and being fraught with subjectivity. And this is when we started learning from the incredible people at the Division of Geriatrics, including people like my mentor, our mentor, Ken Kavinsky, who's in the audience, that frailty is actually so much more than you know it when you see it. It's so much more than the eyeball test. In fact, it's actually a formal construct that has been defined and codified in the field of geriatrics, most commonly by this definition, a distinct biologic syndrome of decreasing physiologic reserve and increasing vulnerability to health stressors.
Put visually, because that's a mouthful, this figure on the right here shows in red somebody who is frail compared to the line in blue, somebody who is not frail. In the beginning, the frail patient begins at a lower functional status, plotted on the y-axis, and as time moves on the x-axis, when exposed to an acute stressor, and those beautiful little red lightning bolts are those stressors, organ transplantation being an extreme example, a frail patient will experience a disproportionate decline in health status, potentially a slower and prolonged road to recovery, and at the extreme, potentially catastrophic health events such as death.
And many thanks to the field of geriatrics, this construct of frailty has more than just had a definition, but it's actually been operationalized by a number of tools. Just a few examples are shown here. These ones have all been tested in either or both the liver and lung, the end-stage liver and lung fields. And these are just some of the metrics to measure either frailty as a whole construct or some of the major components of frailty. In the field of geriatrics, in older populations, frailty has time and time again been shown to predict mortality. Here is just one of the many survival curves that exist that look exactly the same. This was a very large population-based study that looked at frailty status in community-dwelling adults over the age of 65 years old, and you can see how beautifully frailty stratifies risk of death, with the patients who are frail experiencing the highest risk of death compared to those who are pre-frail or compared to those who are robust. What's so interesting about the construct of frailty is that even though it's existed for, it's existed now for 30, 40 years, but now it's been extrapolated into the general population. So it's not restricted to 65-year-olds. And it has been shown time and time again to also predict risk of death in the general population. This is one huge study of over 500,000 patients in China over the age of 18 years old. And you can see that frailty is strongly associated with risk of death from all causes shown at the top, but then all other causes of death. So ischemic heart disease, cerebrovascular disease, you name it, frailty is strongly associated with risk of death in these populations.
And I will say, incidentally, as somebody who works in boutique populations where we may do 75 to 100 transplants a year, I can only dream of working with data sets with 500,000 people.
We got to work a lot longer than 15 years, John, for that. So these kinds of data, though, did make us wonder, could we import this construct of frailty from the field of geriatrics into our end-stage organ failure patients and see if frailty can help us kind of solve that unmet need of figuring out, you know it when you see it, or too frail for transplant?
And when we began, it really wasn't obvious that it would be. I mentioned that when patients are referred for transplant, they are heavily scrutinized for fitness for transplant. And so we are talking about a population that's very different from community dwelling older populations or really other less highly selected people. Transplant eligibility is strict. We look at patients from head to toe, internal organ function, external function, psychosocial fitness for transplant, making sure they have teams around them of family members or loved ones to support them. They have to pass the so-called eyeball test by our clinical teams. And so we really weren't sure whether this would be a concept relevant in our fields, but the stakes were really high. You hear in the lay press, there are people dying every day waiting for organs. Organs aren't widely available, and so we have to really get it right. And for liver transplant, despite that heavy scrutiny of the patients and identifying those we think will do well, 1 in 5 die while waiting for a liver. While our waitlist survival is marginally better in lung, 1 in 3 globally will die within 3.5 years after undergoing lung transplant. I do want to shout out, as Bob did, our UCSF liver and lung transplant programs. We are top 5 in the country, and our survival is better than what I showed you here. But nevertheless, mortality is quite prevalent. So we got to work.
Wait a minute, John. I don't know what your day-to-day life looks like, but mine certainly does not look like this. My daily life looks a little bit like this, as my study coordinators know. And so over the last 10 years, since we started formulating our research program, we did get to work behind a computer screen. And on the liver side, we formed the Frailty study, which stands for Functional Assessment in Liver Transplantation. Since 2012, we've been enrolling patients with cirrhosis awaiting liver transplantation who undergo objective assessments of frailty and physical function and quality of life, both before and after transplant in a longitudinal fashion. And we've also expanded this to 8 liver transplant centers in the United States. And I just looked at our numbers that my coordinators gave me this last week, and we're at about 3,200 patients recruited from UCSF and over 4,500 nationwide. I really want to give a huge shout out to the Frailty study team. My study coordinators are sitting here in the second to last row, without whom this would not be possible. Also, a shout out to Ken Kavinsky, my primary mentor, who really supported me on this, as well as a lot of funding agencies who helped supported this, including lots of funding from the Department of Medicine and the UCSF Liver Center. And with this research infrastructure, one of the first things we wanted to demonstrate was, does frailty sort of work in this population? Does it really describe and risk stratify patients in this population? Well, the first thing we did demonstrate was that cirrhosis is indeed a state of accelerated and premature physiologic aging. We found that 20% of our patients with end-stage liver disease are frail. 40% are functionally impaired. At least 1 in 3 are reporting difficulty with one activity of daily living. These are the basic necessities and functions of life. And when we look at these rates of frailty and disability and functional impairment, our patients with cirrhosis with a median age of 57 years are displaying the same rates as 85-year-old community dwelling adults. So every time we walk into a room and we see a patient with cirrhosis and we say, looks older than stated age, it's true. They are physiologically older than their chronologic age. We also had an early study in which we demonstrated that this construct of frailty really did predict mortality in our patients with cirrhosis. Again, not geriatric, median age in the mid-50s and now approaching 60. You can see here in this figure that the patients who are frail, shown in the gray bars, have significantly higher rates of death on the wait list than those who are not frail, which are shown in the white bars. The two bars on the left are the people with a lower liver MELD score, so MELD score of 18, who would not be predicted to die very quickly, and the patients on the right with the MELD score of greater than 18 are the ones who would be predicted to die sooner. And regardless of MELD score, this is the liver function metric by which we prioritize patients on the wait list. Frailty rises to the top as a top predictor. What's even more interesting is that the frail patients, regardless of their MELD score, have the same rates of waitlist mortality, suggesting that there really is something to this frailty metric. It really is adding value to the MELD score alone. This study was done with the Freed frailty metric, a classic geriatric instrument of physical frailty, but we also showed the same rates of functional impairment and the same prognostic value when we used other geriatric instruments, such as the short physical performance battery, activities of daily living, the IADLs, or the clinical frail scale. But we weren't ready to take these instruments into clinical practice, even with these powerful associations with mortality, because there were problems with these metrics. There were subjective components in it. If those of you who know the Freed frailty metric, for example, you ask the patient, do you feel exhausted? So, you can't really decide whether a patient is going to be on the transplant list or not. based on them answering a question. There were significant floor and ceiling effects. We did find that the ADLs, for example, the majority of our patients in certain circumstances could perform all their ADLs. So it really wasn't granular enough for use in the transplant setting. And there was the problem that they were just developed in non-end-stage organ disease populations, so probably weren't scaled for our population. And so the next step in our liver transplant team is that we used our frailty study to develop our own organ-specific metric called the Liver Frailty Index. We sort of put all of the geriatric measures in a statistical blender and came up with our own, consisting of grip strength, chair stands, and balance. And honestly, working with the statistician, actually John Buscarden in the Division of Geriatrics, it really did feel like we just kept blending and blending, and we looked at a bunch of different metrics. It was a very, very fun process, and we decided this was going to be grip strength, chair stands, and balance. Thank you to my study coordinator, Shri, for volunteering to take a picture of how to do the chair stands. And the first thing we did with this metric is just to show, well, does it map to the construct of physical frailty as developed originally by Freed in sort of the geriatrics literature? We did find that patients who were frail by the Liver Frailty Index did have significantly slower walk speed. They did report more difficulty with instrumental ADLs. They did report significantly higher rates of exhaustion. They did report significantly lower rates of activity during their day. So it definitely mapped to the construct of frailty. We also wanted to provide the community with a general distribution of what are the general liver frailty index scores in patients with cirrhosis awaiting liver transplantation. And so this was it. And we scaled it, and we sort of wanted to visualize it such that the community could envision this index looking like the MELD score. The higher the number, it was a linear number, continuous index. The higher the number, the worse the patient was. The higher the MELD score, the more likely they are to die. The higher the liver frailty index, the more likely they are to die. And then we demonstrated that it was strongly associated with mortality. Here you can see that patients who are, it looks like the figure that I showed you in the geriatric population, where the patients who are frail have significantly higher rates of mortality than people who are pre-frail and people who are robust. And this was independent of the MELD score, which is that liver-specific index. And in fact, we found that frailty, as measured by the Liver Frailty Index, was associated with a twofold increased risk of death on the wait list, and that frailty was essentially equivalent to adding 9 MELD sodium points of mortality risk. For those of you who are familiar with using the MELD score, that is an enormous difference on the wait list. When you take a patient from a MELD of 20 to 29, that completely changes. It changes whether you leave them at home or you send them to the hospital. And lastly, we wanted to make it we developed this index so we could use it for transplant. So we started using, we wanted to use it. And how do you do anything in clinical care around here? You got to get it into EPIC. So we were so grateful to work with the EPIC team, and actually through liaisons through the Department of Medicine and the EPIC team, who helped us get a frailty flow sheet that we have made available to the community in the community library, that all these other centers around the nation are also using in their EPIC. And we can pull it in with a smart phrase. You've made it when you have a smart phrase. And we can actually pull in longitudinal values as well. So that's what my work actually looked like over the last 10 years, John. I know at the same time, even if your work looks physically a little bit different in a silhouette, I know you were equally hard at work. What were you up to?
Trying with less visually impressive graphics to recapitulate what you were doing. Jen's ability to brand and name things is legendary, and I want to learn from you. But in lung transplant, our field faces much smaller numbers. So right out of the gates, we had to begin our lung transplant body composition study as a multi-center study, including UCSF, Columbia, and the University of Pennsylvania. Somehow, all of the UCSF research team members, some of whom, are here. Thank you. The UCSF team members that I work with are listed here. Many of them are in the room, so thank you for coming. I also want to highlight Ken Kavinsky, who's one of my mentors as well. And also wanted to highlight that with our lung transplant research program, it is heavily embedded within our clinical team, shown here on the far right. And all of the members of this team are deeply invested in the research mission at UCSF and our work. Much like you, we began at the beginning, right? Start with the instruments that have been tested and tried and true in older community dwelling populations. I've listed 2 here that you've heard some about, and we measured these metrics in people on the wait list for lung transplant at our 3 centers, and then we followed them forward in time. An advantage that we have in lung transplant is there is no loss to follow-up. Once they are part of our transplant program, we can see what happens forever, which epidemiologically is really helpful. And we found much the same that you did, which was frailty, whether by the short physical performance battery or free frailty phenotype, was strongly associated with dying on the wait list or being delisted for becoming too ill to undergo the rigors of a transplant surgery. And these were adjusted for the things that we normally think about would predict risk of death on the wait list. The other thing we found, much like Jen, is frailty was prevalent. 1/4 of our patients were frail, and these are folks we had screened, put on the wait list, had met our eyeball test. And like Jen's population, our patients were relatively young, those who were deemed frail, median of 59 years. And those who were frail compared to those who were not discernible by comparing ages. We followed this up and found that if you were frail going into transplant, you had a markedly higher risk of dying within the first year after transplant. And these are survival plots on the left, and on the right, I wanted to put it in absolute terms, that frailty as an individual risk factor is associated with a 12% absolute increased risk of death within the first year after transplant. Like Jen, right out of the gates, we were seeing issues with generalizability. I'll give you one example. The free frailty phenotype, one of the criterion is, are you physically active? And the way that's assessed is by administering this survey, the Minnesota Leisure Time Activity Questionnaire, which asks people how many minutes and how many days a week do you spend playing racquetball and playing tennis and going swimming and doing lots of things that no patient with end-stage liver or lung disease ever does. And we found that despite being required to exercise daily to maintain fitness for transplant, that 42% of our respondents to this survey answered that they expended 0 kilocalories per week in physical activity. So that's a problem. And so as a proof of concept study, fairly early on, we looked to another activity questionnaire, the Duke Activity Status Index, that was developed for people with heart and lung disease. And we substituted that measure in. And I like the statistical blender comment. We found a cut point using those techniques for the DAISY, and found that substituting the Duke Activity Status Index for that other survey improved our ability to discriminate who would die on the wait list for transplant. And this gave us early confidence that we could start thinking about going back to the drawing board, much like Jen did, on how to measure frailty in end-stage lung disease that wouldn't be so confounded with the disease itself of respiratory failure. We went back to the origins of measure development. These are the concepts in frailty measures. These are how they've been operationalized in existing instruments in the community dwelling older population. The benefit we had is we also could benefit from 30 years of advances in geroscience when we began to undertake this work. The geroscience, or the study of the biology of aging, there was a lot of work that went into understanding how some putative mechanisms by which frailty may emerge. And this is sort of an amalgamation of a variety of different figures selected for lung disease that I thought might represent possible pathways to explore. And so worked with some amazing translational and basic scientists in our division, John Greenland, Danny Calabrese, and Paul Walters, to include the conceptual physical measures of frailty that I highlighted in gray there, but then add on advanced metrics of body composition, and then these other potential pathways listed here. And we use serum biomarkers for that work. Worked with Patty Katz in the Division of Rheumatology, who's a psychometrician and measure development expert. And we were able to come up with the lung transplant frailty scale. Much to my chagrin, the lung frailty index had already been claimed as the liver frailty index, so went with another name. But we were able, with these biomarkers, to develop 3 different frailty scales, from the most simple, which we call the base, which is the most clinically deployable, measuring balance, grip strength, gait speed, and clinically available CRP, all the way through a research-based biomarker version. And across the 3 scales and increasing complexity, we showed improved discrimination, but all of the measures had substantially superior performance when compared to the available measures developed in the geriatric population. And so for us, Jen, I think even though we were working in our respective fields, the common thread, I think, over the last decade of our work was to really focus on demonstrating to stakeholders in our fields that frailty was important, and it provided information we didn't otherwise have, and it was strongly associated with the ultimate outcome, which is death. And by focusing on that, which is an outcome our people in our fields very much appreciate, they enabled us to get a hold of the attention of our communities.
And boy, did we get their attention. In the last decade, the construct of frailty has been integrated into a number of different consensus statements in hepatology, in pulmonology, in liver and lung transplant and solid organ transplant. You can just see here a selection of some of those consensus statements in which frailty has either been featured as the thing that the consensus statement was built around, or frailty has been integrated into the standardized evaluation of individuals with end-stage liver and lung disease undergoing liver transplant evaluation. So we feel very proud that what we have done up until now has really gotten the attention by focusing on this very important outcome of survival. So that brings us up to the present. And as we said, that we really wanted to focus on survival because we knew that would be very important to demonstrate the importance of this index. But as we mentioned in the very beginning, the reason that John and I went into this field was not just because we were interested in understanding which of our patients would survive, but in fact, we're much more interested, and we have always been and continue to be much more interested in identifying which of our patients will thrive and how can we help more of them thrive. And we viewed the work that we had done thus far as the platform to start exploring these questions.
And we looked to actually a sociologist, Saad Nagy, who had developed this conceptual model of disablement that has really framed our work moving forward, where conceptually, as a disease progresses, it causes dysfunction in that organ or the person as a whole, which leads in turn to what is called functional limitations. Those are termed impaired ability to do physical or mental maneuvers in a lab-based setting, like a 6-minute walk test or a pulmonary function test, or in this case, frailty. And that functional limitations are upstream determinants of physical disability, the ability to perform actions in the lived world in your community. And those are all upstream precursors to and determinants of both survival, but also health-related quality of life. And Jen, this was one of the most fun times where I actually got to directly collaborate on a paper together.
Yeah, I think these data come from this is the perfect example that demonstrates how much you've influenced the work of our team, because you guys probably already know by now, having seen his data, that John is an expert in quality of life in end-stage organ disease transplant patients. And in this study, we collaborated to ask patients who had undergone a liver transplant about their quality of life many years after transplant, both 1 year, 3 years, 5 years after transplant. And we then associated their pre-transplant frailty status with their self-reported quality of life after transplant, and found, as you can see here, where the frail patients are in the dark black bars, that they're consistently reporting significantly lower health-related quality of life after liver transplant, whether it be 1 year, 3 year, 5 years after transplant, those patients who are frail are significantly more impaired or are having more trouble with their, particularly the physical aspects of the quality of life after transplant, which is so interesting because if you remember the liver frailty index, it's a very physical metric. It's grip strength, it's chair stands and balance. And what they're suffering from after transplant are physical functioning and aspects of their life related to sort of the physical, kind of physical activities.
And I think this is where our work started to diverge for a period of time, where using this model of disablement, we really started to think about going upstream and ask, what are the risk factors for frailty? We've used frailty as a predictor for outcomes, but what predicts frailty or what causes frailty? And one of the first factors we started to look at was the BMI. And something that's frustrated me for a long time is we use BMI as a criterion for putting somebody on the wait list for transplant. Rationale is population-based studies have shown that extremes of BMI, low or high, are associated with poor outcomes on a population level. Frustratingly, though, it's a poor proxy for what are probably the causal reasons for extremes of weight causing complications after surgery, namely adiposity, an inflammatory state at the high BMI level, and sarcopenia or malnourishment at the low BMI level. And so we wanted to use a variety of different technologies to look at body composition a little more deeply, whether it be DEXA scan or CT scan or bioelectrical impedance assays. And as just one example, this is looking at a cross-sectional study of lung transplant candidates at our 3 centers. We found on this left side that decreasing levels of muscle mass relative to somebody's height, appendicular skeletal muscle index, decreasing levels of ASMI appear to be fairly linearly related to the risk of being deemed frail on a physical function measure. And on the far right side, we showed similar relative linear relationships between increasing percentages of body fat and risk of frailty. And these are generalized additive models, so we controlled for things like age and sex and other factors. And so up until now, we've really shown you data on frailty in lung transplant candidates that were measured at a single point in time. But as I bragged, in organ transplantation, we get to follow people longitudinally, and it gives us the sometimes unique opportunity to see how things evolve. And frailty either happens, goes away, or comes on.
So we took advantage of the cohorts that we had that were prospective and longitudinal. And actually in liver transplant, we looked at how does frailty change after liver transplant. So here's some early data from just like our first cohort of about 250 patients. And pre-transplant, their median liver frailty index scores were 3.7. This falls in between the shading is not very good, but robust is in the low part and frail is in the high part. It falls kind of right in the middle. Okay, so this is pre-transplant. This is when they had end-stage liver disease. 3 months post-transplant, their liver frailty index goes up. That means it got worse 3 months after transplant. Really speaks to the stressor of surgery, right? It's a major surgery, so it really takes a lot of physiologic reserve from our patients. And it's only until 6 months after transplant do they start becoming better physically and returning back to their pre-transplant frailty status. Now, this might be expected 6-month recovery from a major surgery, but before transplant, they had liver failure. They weren't able to synthesize proteins. They had ascites, they had hepatic encephalopathy. They couldn't even clear toxins from their body. And now 6 months after transplant, they have perfect liver function, but they're physically functioning the same as they were when they had end-stage liver disease. Again, going to this idea that what we saw initially, they had perfect liver metrics, they had perfect lung metrics, but as a human, as a whole person, they weren't quite functioning perfectly. And it wasn't until 12 months after transplant did they actually start to get better than their pre-transplant state. So a full 12-month recovery to only get a little bit better. And unfortunately, only 2 out of 5 met criteria for robust 1 year after transplant. And just to give you a sense, if I tested all of you with the liver frailty index, your scores would be like 2. I mean, this is not a very extreme metric here. It's not a very high bar to get into the robust category. So when we say like John and I wanted to help patients thrive after transplant, help them get to be rock climbers. These data were showing that we were falling very short.
And in lung transplant, we were able to follow people. This is a UCSF specific study where we measured frailty as well as patient reported outcomes from before and then repeatedly out to 3 years post-transplant at those time points that I mentioned there. And we found that about 1 in 5 patients after transplant developed incident or new frailty. And using these longitudinal measures, we found that figure I had shown you previously, the development of sarcopenia, adiposity, malnutrition, or chronic kidney disease at one of those follow-up visits or labs based in between those visits, operationalized using the measures you see in the middle, were strongly associated with being deemed frail at the next follow-up visit. These were patients who were not previously frail, suggesting these were independent risk factors for the development of incident frailty after transplant. And we also found that when frailty emerged, no matter at what time point after transplant, from 3 months all the way out to 3 years, on the left, patients who were frail reported substantially worse health-related quality of life by all the various metrics we used. I just showed you 2 here. And that when frailty developed, it was associated with subsequent increased risk of death at a 2.5-fold level, adjusting for allograft function. So frailty was independently identifying people at increased risk for death that was occult using our regular clinical measures.
So up until now, we've really been focusing on, we've been calling frailty as that sort of the measure of the whole person, but you've probably noticed that we've been using metrics that are much more physical, right? Whether it's chair stands and balance, whether it's the body mass index, the sarcopenia, the adiposity, these are all quite physical measures. But as we know from the field of geriatrics, frailty is actually more than just physical and muscle and strength, but it actually is cognitive. And some of the work that we've been doing in our current time in the liver world has been focusing on this concept of cognitive frailty, if you'll let me call it that. And so we've been partnering actually with some incredible researchers at the Department of Neurology. One of the great advantages of working at UCSF, they're just really smart people in many departments all over the university who are excited to work together and do new things. And we did a study in liver transplant recipients, a median age of 58 years. And we just wanted to get a sense, well, what was their cognitive function after liver transplant? So we wanted to take patients who had no history of hepatic encephalopathy ever in their pre-transplant life. And they had actually pretty high education status. 3/4 of them had over 12 years of education. We found that the median MoCA score in liver transplant recipients was 26. The maximum score is 30. And actually 1 in 3 had a MoCA score of less than 24. Now, if we take these rates and we extrapolate them to the general population of older adults, just as reference norms, where do our patients fall? They actually are looking like with a MoCA score of 26, 85-year-old adults with a MoCA score of less than 24. This is a rate that you see in 95-year-old community dwelling adults who have no reported signs of cognitive impairment. So again, more data, even when we get away from physical frailty and go to cognitive frailty, our patients with end-stage organ disease, while chronologically young, are behaving physiologically 20, 30 years older than their stated age. And then we did another preliminary study to see, well, are there things that are happening in that cirrhotic state that might predispose them to cognitive impairment and ultimately dementia, which is a study that is ongoing here. But we did actually measure plasma biomarkers of neuropathology. And in particular, some of these are being increasingly recognized as markers of Alzheimer's dementia. And we found, you can see that middle column of patients with cirrhosis, significantly higher biomarkers of neuropathology in patients with cirrhosis compared to controls, suggesting that cirrhosis itself is a risk factor for dementia. This is very interesting information because most of the work that include huge numbers of patients with dementia, including Alzheimer's, are excluding patients with any known liver disease at all, including those with cirrhosis. So this is really adding a whole body of research and adding studies of liver disease, liver dysfunction, and cirrhosis as a risk factor of dementia. So this brings us up to where we are now. And so now we get to think about what are we going to do for the next 10 or 15 years? And I don't know about you, John, but as I was coming up with how to describe it, I know you're digging foundations for the new research building, and I'm sitting in front of my computer all the time, but I think the next 10 or 15 years should look a little bit more like this.
I completely agree. Unfortunately, I think it's going to continue to look like this, but it's getting increasingly fun. And so as we look forward to the next 10 or 15 years, I think as Jen and I think about what Frailty has provided us in our fields, I think it's provided us a framework and a springboard to really think broadly about how we can improve organ transplantation across the journey with a focus on the whole person. And we're just going to highlight a couple of examples that excite us. One is the question, is frailty all the same? I've shown you this figure before. If there are multiple putative pathways by which somebody can become frail, is a frailty measurement that we do at the bedside really measuring the same thing? And there's strong precedent from our division, featuring Carolyn Calfee here, that there is heterogeneous biology in other syndromes. And I highlight ARDS, lung injury in ICU patients who are typically mechanically ventilated. It's a clinical syndrome. And Carolyn, working with Kevin DeLucci, a statistician in the Department of Psychiatry, explored this concept called latent class analysis, which, if you will permit me, if there is an observed distribution, let's call it ARDS or frailty for the purposes, could that single entity actually represent hidden or latent different biological conditions that are all getting lumped into one? And she, using this concept and modeling technique, demonstrated in multiple study after study after study in ARDS clinical trials that there are actually two subphenotypes of ARDS. One she termed hypoinflammatory and one she termed hyperinflammatory, and showed again and again that these conditions had dramatically different outcomes, even though they were all deemed to have ARDS. And so we adopted that and worked with Carolyn and Kevin to ask, is there heterogeneity in frailty in advanced lung disease? Use the same measures you see here representing many of these pathways articulated on the left side figure. And we found that actually there were two classes, i.e. two latent classes that really explain the distribution of these various measures better than one. And this orange line shown here is a plot of the standardized mean values of these various markers, measures of systemic inflammation on the far left, measures of muscle strength, mass, function on the far right, and showed there were very divergent populations. About 1 in 5 of our patients, incidentally, they were 6 years younger than the other group. 1 in 5 had this inflamed, sarcopenic, malnourished subphenotype, even though they all met the diagnosis of having frailty. And we found that the inflamed sarcopenic subphenotype had worse outcomes. They had a 3-fold higher risk of dying on the wait list for transplant. And because this is a fairly new study when we put it out, not many of the cohort had undergone transplant. And so our early look at some postoperative outcomes showed that that inflamed sarcopenic subphenotype had increased risk for unplanned, sometimes emergent takebacks to the OR, many of them bleeding, increased hospital length of stay by multiple days, and strong trends toward ventilator-free days and other surgical complications.
So John, while you've been going in this exploration of the underlying biology and the mechanisms of frailty, we also have been doing a sort of similar exploration of the biology of frailty in our liver patients. And the phrase that I still always love is older than stated age. It was just like one of the first things that I was thinking about when I saw a patient with cirrhosis when I was a medical student. I thought I had walked into the wrong room, because on paper, he was supposed to be 50, and in real life, he looked like he was 80. And so I partnered with some researchers at the Buck Institute and the Department of Neurology, and we did this very preliminary study. We took 7 frail patients and 5 robust patients. We did genome-wide DNA methylation status using techniques that they did in their lab, and calculated each patient's epigenetic clock using pheno-age. And then we actually sort of determined whether there was any evidence of biologic age acceleration based on this epigenetic clock. And what we found is that you can see the frail patient on the left figure. The frail patient actually was, in fact, a couple years older by their epigenetic clock, biologic clock, as compared to the robust patient who was a few years younger than their chronologic age. These are small differences. Now I'm getting older, so it's like, if you're 45 or 47, it's all the same. But I mean, this is pretty interesting using these methylation clocks or these epigenetic clocks to see that there's actually kind of a big difference between someone who's phenotypically frail and someone who's phenotypically robust. And then on the right bar, or the right figure, you can see that those who were epigenetically older actually had higher rates of poor outcomes, death or readmission in the hospital, compared to those who were epigenetically younger.
The last thing I'll highlight is that Jen mentioned in our international consensus document for the selection of lung transplant patients, it is now recommended that a comprehensive clinical evaluation include a measure of degree of frailty, which is really impressive. But what I get all the time is, okay, that's fine, we found it. Now, what are you going to do about it? And access to pulmonary rehab is a big issue. We do know that exercise and nutrition interventions have the ability in many other populations to address many of the putative causes of frailty. And as a proof of concept study done a few years ago, small one, we showed that a remote on-demand tailored rehabilitation program delivered over mobile devices, we could exercise patients safely who were on fair amounts of oxygen at home and some had pulmonary hypertension, and that frailty could resolve in some. Now, the adherence to the program, despite this highly motivated population, was modest. And what we all know for any of us who've tried to continue to go to the gym is exercise really fundamentally is a behavior change. And so have partnered with a neuropsychologist and expert in lifestyle interventions in advanced lung and heart diseases at the University of North Carolina to develop a rehabilitation program to exercise lung transplant candidates, and hoping to hear from the NIH later this month whether our randomized control trial will get funded.
So prehabilitation is definitely the holy grail of frailty work. We would love to reverse it. But in the meantime, as we're trying to get our prehabilitation programs up and running, our team in the liver world is trying to explore other ways to integrate frailty into clinical decision-making today. So one of the things that people are very interested in the liver community is, well, if frailty is strongly associated with mortality and we prioritize patients for liver transplantation by risk of mortality, can we add frailty to the MELD score to actually better prioritize patients for liver transplantation? And so actually, this is a study that is being led by Melinda Wong, who's an internal medicine resident, who's spectacular and also a future hepatologist. And she is leading a study where we looked at the current MELD score, it's called 3.0, and added it to frailty. And she did some statistical work with that and actually found that adding the liver frailty index to the MELD score significantly improves the C statistic for prediction of 3-month mortality, moving the C statistic from 0.78 to 0.81. Now, this may not sound like a huge number in difference, but I will tell you that we have changed our national liver allocation system twice in the last 15 years based on improvements in the C statistic by hundredths of the point. So this is the kind of difference that really changes the way we allocate organs. And you can see here in this figure, when we stratify patients by both their MELD score and their frailty status, you can see the patients in the black bars at the top are the patients with the lower MELD scores. The patients with the aqua, who are in aqua, have the higher MELD scores. But you can see the curves in the middle. You can see the aqua and the black lines match. And that's where frailty basically overcomes the MELD score in risk prediction. Again, frailty is like adding 9 MELD sodium points to a patient's mortality risk. And lastly, we have been partnering with the members of the Division of Palliative Care. So thank you to, again, the Department of Medicine for supporting that, to help use frailty to stratify patients for palliative and integrative health approaches to manage suffering. We have found that frail patients report significantly higher rates of physical distress, pain, and suffering. And we have been using this metric to refer patients who are frail for early palliative care. And we have found that this has significantly improved their rates of advanced care planning documentation, significantly improved clinician satisfaction with managing patients with these very complex liver patients who are frail and with a lot of symptoms.
So I think over this past hour or so, Jen and I hope that we've been able to show you how we've leveraged insights from fields of geriatrics and sociology and neurology and physical therapy to really advance a focus in liver and lung transplantation from one inherently focused on survival alone to one that focuses on the patient as a whole.
We would like to extend an enormous token of gratitude and thanks to Dr. Wachter and the Department of Medicine for the incredible initiatives that they have supported to support our research, not just supporting an incredibly collaborative department as a whole, but the funding dedicated to supporting our research programs. You can see here, this came from the research website from the Department of Medicine. John and I have actually tapped into virtually every single one of them over the last 15 years of our research career. We could not have been here without that. So thank you very much.
I want to close with a special thank you to all of our patients who we consider our true partners in this effort to improve the outcomes for people with lung and liver transplantation. Thanks.
What an incredible story and of collaboration and bench to bedside, really quite wonderful. We have a few minutes for questions. Let me just start out with, it's still not clear to me today, does your frailty index influence whether you will get a transplant or not? And should it influence whether you get a transplant or not in both of your fields?
It does influence whether our patients get a transplant or not. It is actually, the liver frailty index is reported during selection, and it's reported like any other metric: the MELD score, comorbidities, echo results, pulmonary function tests, urinalysis, and then liver frailty index, and it does get incorporated into it. Now, the question of should it, there's always the controversy of, well, a frail patient may be at higher risk of waitlist mortality, but will also have a higher risk of post-transplant mortality. The reality is we are using frailty no matter what. You saw that our story started with the eyeball test. Our clinicians are using the eyeball test to determine whether patients get on the waitlist or not. What we wanted to do is make sure that eyeball test is anchored with objective information to make sure that if we're going to use it, it at least is objective.
A little less so. There's a joke by one of our famous surgeons who says, once you've seen one lung transplant program, you've seen one lung transplant program. I think it varies between programs. One thing I do want to highlight that we didn't show here is that most of the frail patients we take to transplant, using these measures, survive and do well after transplant. And so it makes us very uncomfortable because we have not yet gotten down really well to the individual level of prediction to make listing decisions.
Right. Yeah. Also, it's such a tricky construct because imagine that some of the frailty is your organ that's dysfunctional. If you fix it, maybe that's better. And probably there are other people in whom the frailty is unrelated to their organ or deconditioning or something. Those feel like very different use cases.
Absolutely.
Yeah. Let's open up, see if anybody has any questions. Yeah. Say who you are.
Oh, Nader Najafi from Hospital Medicine. I was curious if the frail versus robust patients have different causes of their liver dysfunction or lung dysfunction. I mean, if I had to guess, I would think maybe an autoimmune hepatitis patient would be more likely to be robust because maybe the disease only hurt that organ more versus an alcohol associated. I don't know if that's true though.
Yeah, so we have found that patients who have metabolic dysfunction associated liver disease, which used to be known as NAFLD or fatty liver disease, actually have higher rates of frailty. So it does seem like the confluence of all the comorbidities, obesity, sarcopenic obesity, hypertension, hyperlipidemia probably does increase rates of frailty. But once a patient is frail, regardless of how they got there, frailty still predicts mortality.
We find similar rates across our disease indications, and there are many for us.
Yeah. Over there? Yeah.
Hi, I'm Brandon, resident internal medicine. I'm wondering, thinking more broadly, should we really be using the frailty and death and disease in place of age? As I see often that older patients are categorically or strongly discouraged from intensive therapies. And I wonder if we're actually just using age as a sort of a proxy for frailty, and if this is better.
You should come join our programs.
Absolutely.
So yes, the idea with these metrics is we are trying to get at biological age as opposed to chronologic. So for some therapies, I think that makes a lot of sense. I think the challenge in organ transplantation is there's another layer of ethics, right? And access to a limited number of organs, which isn't necessarily part of the discussion in other types of therapeutics.
Some online questions from the 80 people watching. Have you looked at telomeres in frailty? What about racial disparities in frailty? And how do you reckon frailty with the falling US life expectancy?
Do you want to start with any of that?
I don't know.
Yeah,
Telomeres?
So telomeres, very preliminarily, we have some bank samples in John Greenland's biorepository. We did this quick look a few years ago, didn't see an association with telomere length, which has been recapitulated in older population community dwelling folks in a variety of countries. We do see racial and gender disparities, much like in the general frailty literature. Our African-American patients tend to have more frailty and women have more frailty, which is same
By objective measures.
By objective measures.
And what's your hypothesis to what that's about?
I don't have any idea.
Yeah, when we turn to Jen, maybe she does. Do you have any?
I was going to try to tackle the declining life
Go ahead.
expectancy. So, I would say that if we really return to the roots of frailty as the end manifestation of sort of the confluence of all of a person's comorbidities, we are seeing persons with lots of comorbidities these days, the obesity and the obesity-related conditions. And therefore, I think frailty will only emerge in newer data as increasingly prognostic, because especially in our end-stage organ populations, where a frail patient is no longer going to be just frail because of their liver disease. Nowadays, the vast majority of my patients are frail because of their hypertension, hyperlipid, diabetes. And so I think we're actually going to see increasingly frailty is becoming a stronger and stronger predictor as it reflects the whole person and more than just the organ dysfunction.
I can't leave with that. We have two experts on frailty. The topic of frailty is going to be a dominant topic in the political race this year. You're already hearing it. So when you hear this, what do you think?
Oh gosh, I don't think I was thinking.
Nobody wants to touch that one?
Not it.
I'm going to stay away from that one too.
You're going to stay.
I want to stay employed.
All right, we should let you all go. Thank you for a terrific presentation, for really amazing body of work. Thanks so much.
Thanks for the invitation.